Good evening to one and all present here for the webinar on neuropsychological assessment today. I would like to welcome Dr. Gopukumar Kumarpillai, neuropsychologist, BNC Bengaluru. I welcome you, sir.
Thank you.
I, I heartily welcome Dr. Rajani Pai, Director, Manasa Trust. I welcome you, ma'am. Dr. Preeti Shanbag, Academic Director, Manasa Trust. I welcome you, ma'am. I would also like to welcome Sister Mary Evelyn, Coordinator of PG, Kateel Ashokapai Memorial College. I welcome you, ma'am. I heartily welcome Dr. Archana Bhatt, HOD, Department of Psychology, Kateel Ashokapai Memorial College. I welcome you, ma'am. I would like to welcome Dr. Sandhya Kaveri, Principal, Kateel Ashokapai Memorial College. I welcome you, ma'am. I heartily welcome all the participants who are present here. I welcome you all. Finally, I welcome all the staff members of Kateel Ashokapai Memorial College, Shivamogga. I welcome you all. Preeti ma'am and Rajni ma'am will join us shortly.
Thank you for your introduction. So I think somebody is going to.
I request Dr. Gopukumar Kumarpillai sir to wait for 5 minutes as there is a delay.
Yeah, no issues.
ಇಲ್ಲಿಗೆ ವಾಪಸ್ ಬೇಡ ಮಾಡಾಯ್ತು. ವೇಟ್ let it be.
I request Dr. Sandhya Kaveri ma'am to give the prefatory remarks.
Thank you, Kirti. Respected resource person of today's webinar, Dr. Gopukumar sir, our Director of Manasa Trust, Dr. Rajani Pai, Academic Director, Dr. Preeti Shanbag, Coordinator of Postgraduation Studies in Psychology at Kateel Ashokapai Memorial Institute, Sister Mary Evelyn, HOD of Department of Psychology, Dr. Archana Bhatt, all the faculty members of Kateel Ashokapai Memorial Institute, students, and all the respected participants of the webinar. This is the great privilege to have a renowned psychologist, Dr. Gopukumar sir, with us for this webinar. So on behalf of Manasa Trust and Kateel Ashokapai Memorial Institute, I cordially welcome Dr. Gopukumar sir for this afternoon.
Thank you, madam.
Thank you, sir.
Thank you.
Kateel Ashokapai Memorial Institute is an educational institute which has been started in 2017 in the name of Dr. K. Ashok Pai. Dr. K. Ashok Pai, a renowned psychiatrist, a B.C. Roy awardee, is not only a psychiatrist by profession, but also has great interest in reaching the mental health through the doorsteps. So he used all forms of methods and the tools to reach the mental health to the doorsteps. With that, we have started different units under the head of Manasa Trust. We have Manasa Hospital, which is headed by Dr. Preeti Shanbag as the chief psychiatrist. It is 100-bedded hospital. Along with that, we have Neuropsychology Center, where the director is Dr. Vaman Shanbag. We have Rehabilitation Center Manasadhara, a geriatric neuropsychological care center, Mukunda. We also have Manaspurti, a child guidance center. Along with that, we have Manasa Education Foundation for Mental Health, which offers distance course in counseling. It offers 1-year diploma courses for the lay counsel. It is lay counseling course offering program. At the same time, this college, Kateel Ashok Pai Memorial Institute, mainly offers education in psychology undergraduation program as well as post-graduation program. We have BA, BSc in psychology, post-graduation MSc in psychology affiliated to Kuvempu University, MSc clinical psychology affiliated to Rajiv Gandhi Health University of the state. Along with that, we are also awaiting now MPhil program from RCI. As a educational institute, we are not only restricted to classroom teaching and learning, we also believe in the overall development. We also know the responsibility of reaching psychology or mental health to the wider population. With that interest, we are also having this lecture series, Mental Health Yatra. Since 2018, we are conducting special lectures by the experts on different topics of mental health and psychology to create interest among the community related to the psychology discipline, as well as to help the students to enhance their knowledge in different areas of psychology, with which they will be able to gain adequate competency to become professionals in future. So since 3 years, we are having different webinars on different topics related to adolescence, then addictions, especially technology addiction, adolescence issues, health and psychology, well-being, positive psychology. Thus, each year, more than 10 special lectures have been arranged through online as well as offline mode to reach to the people with the topics of psychology. In this regard, we feel privileged to have the first webinar of 2022 academic year by a renowned psychologist, a very well-known person in the field of neuropsychology, Dr. Gopukumar sir.
Thank you, madam.
Now we are all awaiting for this webinar on neuropsychological assessment with the idea of giving basic knowledge regarding the...
Thank you, ma'am. I, Drishya, from first MSc, Dr. Gopukumar Kumarpillai earned the Masters and MPhil, PhD and PGD in Personal Management and Industrial Relations, followed by 4 years of postdoctoral research and clinical training in neuropsychology at the National Institute of Mental Health and Neuroscience, and 4 years of postdoctoral research and clinical in neuropsychology work at Foothills Hospital, Department of Neurosciences, Calgary University, Canada. He has over 18 years of clinical and research training experience in the psychological field and 14 years of organization management experience. He has made more than 90 of the professional presentations locally, nationally, and internationally. Under his guidance, 3 students has been awarded PhD and is guiding many PhD and MPhil research work. He served as an external examiner for MPhil and PhD degree. His co-authored Nimhan's Neuropsychology Battery is the only neuropsychology battery which is widely used in India. He received international travel grant for his research work in Italy,
USA, Sweden, China, America, Mexico, UAE, and Canada. His research interests are in neuropsychology, behavior technology, counseling psychology, organizational psychology, educational psychology, sports psychology, cognitive impairment, and retraining and psychology of meditation. We are fortunate enough to have you as a guest here. A very warm welcome to you, sir. Over
Thank you.
to you.
Thank you, Drisha. Thank you, Sandhya, madam. Okay, thank you, everyone. Today, the topic is neuropsychological assessment. So, whatever Dr. Sandhya said about, I'm going to discuss about the basic of how to do neuropsychological assessment and why we are doing, and what causes, and based on that, what kind of diagnostics, and based on that, what kind of retraining and training activities actually we can give. So these are all actually, because in India, because neuropsychology is like not that much developed, because there are very few institutions. That Kirti Pai institution, actually they developed a neuropsychology center, some kind of cognitive training and assessment centers and all. So I'm really happy with that, and with that brief introduction, I'll start the topic. So what we are going to do, we are actually going to see how neuropsychological assessment plus some case studies, because I will explain so how they perform in clinical setup, how they perform, and what are the activities we can do, because we can have one more session also about cognitive retraining activities. But anyway, this is a wonderful start. Okay, so okay, neuropsychological assessment is a performance-based method to assess cognitive functioning. So it's a kind of a performance, because in front of you somebody sits and they just do, we give some activities, they do, then we assess their performance. Then through that we'll understand their cognitive functioning. Okay, this method is used to examine the cognitive effects of brain damage, brain disease, and severe mental illness. Okay, brain impairment due to head injury, substance abuse, stroke, or other illnesses and injuries. Brain impairment impacts the cognitive ability to use language, think and make appropriate judgments, perceive and respond to stimuli, and remember old or new information. So these are all actually will be assessing. So what we see here, so you have hearing, understand, vision, movement, memory, judgment, self-control, all those things. So what we do, so this is why actually we do neuropsychological, to understand the person. So hearing, that is actually nothing but auditory perception, is the ability to perceive sounds through organs such as an ear by detecting vibrations as periodic changes in the pressure of a surrounding medium. Then we have understanding capacity, that is understanding is a psychological process related to an abstract or physical object, such a person or situation or message, whereby one is able to use concept to model that object. Okay, vision is the ability to interpret the surrounding environment through photopic vision. Movement is the change in the position of a body part with respect to the whole body. Okay, then what else? Memory, the process that are used to acquire, store, retain, and later retrieve information. There are three major processes involved in memory, that is encoding, storage, and retrieval. So first what we do, we give whatever they say something, first we encode it, then stored it, then whenever we want we will retrieve it. So then we have judgment, the ability to make considered decisions, because decision making capacity, and self-control, because the ability to control behaviors, not to avoid temptations and to achieve goals. Then language. A language is structured system of communication used by humans. Languages can be based on speech and gesture, because what we do aphasia assessment to understand their language skills. Okay, now we'll understand psychological versus neuropsychological tests. So what is the big difference between psychology and neuropsychology? So what are the psychological assessment and neuropsychological? The purpose of neuropsychological assessment is not affective, intelligence and personality. It actually assesses affective, intelligence and personality. Okay. So when it comes to neuropsychological assessment, so what we do? Brain dysfunction. So the approach is actually psychology, outcome is what we do. A psychologist assessing on intelligence of a person, so or any kind of assessment. So outcome will be actually retarded. The person is actually retarded or not. That's what we say. The person is adequate or not in psychological setup. That's all. But when it comes to neuropsychology, the approach is actually so we can actually understand which part of the area is affected. We have 4 lobes in the brain: frontal, temporal, occipital, parietal lobes. So in that related assessments are there. So whether sometimes they will be only frontal lobe problems they might have, or they have some temporal lobe. So that means we can actually assess their strengths and deficits. Okay. And the time psychological assessments actually 4 to 5 hours, because for example if you do psychological assessment MMPI, Minnesota multi-basic personality, so 467 or more than that questions are there. So it is actually it takes time to score and this thing, and like there are many. So in general psychological assessment takes 4 to 5 hours. Neuropsychological assessments approximately 8 to 10 hours. So that both the assessments are actually face to face only. But some of the tests, psychological, because most of the time nowadays, because of COVID and other issues, the researcher actually they send it through a Google form. They'll fill it and send it back. So that is now it is not happening face to face also. But neuropsychological assessment we can't do it online or webinar based. So it should be face to face only, because then only we'll understand their strength and deficits. Based on their deficits, we can actually guide them. Based on the strength, we actually leave that particular portion. Okay. So, nature of neuropsychological functions are actually behavior is the outcome of the interaction of brain with the environment. So, behavior is explained at several levels, ranging from the molecular to the psychosocial level. Okay. So, neuropsychology is the bridge between the physical and the psychological explanations. It's actually a bridge between the physical and psychological. So, neuropsychological functions explain cognition, emotion, and volition. So nature of neuropsychological assessment. So what we do when we start neuropsychological assessment, initially we do clinical examination to understand the patient. Then assessment of deficits, because when we do assessment we'll understand what area which functions are affected. So based on that we understand the deficits. Combination of normative and idiometric approaches, because this approach actually it is actually normative. It's actually pure statistical based normative data. We can't even create anything. It's not a clinical assessment, like psychiatrists or neurologists. They do assessment based on the clinical aspects of the person. They can actually assess through MRI, brain MRI, or the blood test, or other clinical examinations they do. But what we do psychologically, we have a normative data, because the test should be standardized based on the standard norms, we use this normative and iodometric approaches. And after that, what we do, once we have the norms for the tests, then we have to create a neuropsychological profile of the patient. Then we have to profile for each function wise. We create a profile. So after that, then whether the tests are actually reliable or applicable to the particular person because of this person's age, education, gender, then whether it is valid or not, and the procedure actually repeatable procedure or not, then these are all the things actually will be we understand. Then later what we do, then diagnosis and treatment part. Okay. Then when it comes to clinical interview, so assessment of motivation, that is actually pre-morbid functions. That the pre-morbid function refers to the level of functioning prior to some pathological event. So that also we understand. And if they have any interpersonal stressors and comorbid conditions. So comorbidity means more than one disease or conditions is present in the same person at the same time. And clinical evidence of mental retardation, because the person is already having some mental retardation. So these are all actually we'll understand through clinical interview. And then what we do, so these are all the methods actually, like clinical observation. What is the clinical observation? The clinical observation is used by skilled psychologists in order to collect information about their patients. They are observations of behavior from the clients that are used in order to determine a diagnosis and treatment plan. So that is the clinical observation. Then what we do, clinical interview. And clinical interview is actually distinct from interviewing that involves, I told you before, actually face-to-face, a verbal and non-verbal exchange between a clinician, that is psychologist, and the client. Okay, designed to gather data that is needed for diagnosis and treatment of the client. Then what we do, then we have a battery, that is actually a set of tests in the neuropsychology battery we have, and we have a neuropsychological tests also. So because in the battery approach means there will be some 21 tests in the battery, then we have to use the battery approach. Then there are neuropsychological tests, we can actually pick it whatever we want, in that way we can do neuropsychological tests. And the goals of neuropsychological assessment actually description. So that description is actually what went wrong cognitively, emotionally, or behaviorally. As a result what we do. So what we do, we tracking changes. They track changes, what actually happened, observe changes in patient's performance over time to monitor healing or worsening and effects of treatment, because over a period what went wrong, and how much is the person actually improved or worsened, and the effects of treatment. These are all actually the goals. Okay, then the purpose of assessment. The purpose of assessment, the administration of neuropsychological tests for the formal assessment of cognitive functioning. So that is to understand the cognitive functions and evaluation of the person's mental status. That is most important for anybody. Initially the person actually comes, then we do basic mental status, then only proceed the detailed battery approach. This is especially true in assessment of Alzheimer's disease and other form of dementia. So what contributes the decline of our cognitive abilities? Maybe high blood pressure, heart disease, stroke, diabetes, acquired brain trauma, that is a sudden injury that causes damage to the brain. So maybe kind of a head injury or sudden injuries, chemotherapy also, because that stroke, cancer patients, they take chemotherapy. Because of that, the brain will be affected. The dementia, so that is the loss of cognitive functioning, thinking, remembering and reasoning, such an extent that it interferes with the person's daily day-to-day activities. Okay. Then Alzheimer's disease. So there are actually 5 stages in Alzheimer's disease. That is that before symptom appears basic forgetfulness, noticeable memory difficulties, then decreased independence. They can't independently do or act anything. And there are some severe symptoms, physical symptoms also, and lack of physical control, and also normal aging. Because of age related cognitive impairment happens. So then we do neuropsychological assessment. So what can be affected by brain impairment? So what are the things we assess in neuropsychological conditions? These are all very, very important. That is actually executive skills, executive functioning, perception, memory, attention and concentration, information processing, movement, balance, fatigue, that is stamina, sensory perception, language, motivation, insight. That is also, again, that when it comes to neuropsychiatry level, because they don't have insight. So no, whatever we say, they can't understand, because they will be their level only, because they what they speak and whom and when, how to discuss. So they don't have much, because most of the psychiatric conditions with cognitive impairment, they don't have much insight to understand the current scenario. Then relationships problems, personality, mood, emotions, impulsivity, tolerance. These are all actually will assess. So what are the consequences and symptoms of neurological damage? Impaired. So these are all the things we assess. What is the impaired orientation, impaired memory, impaired intellectual functions, impaired judgment, shallow, capable of there is serious thought about something, loss of emotional and mental flexibility, and frontal lobe syndrome. So what is frontal lobe syndrome? That is actually damage to the prefrontal regions of the frontal lobe. That is the frontal lobe of brain plays a key role in executive function, mainly planning and execution and problem solving skills, such as motivation, planning, social behavior and speech production. These are all the frontal lobe syndrome, very, very important, because sometimes we do in with the patient actually comes with frontal lobe syndrome, we do only frontal lobe. Their assessments are there, because we do only frontal lobe related. So what and all we do that, because the patient symptoms are decreased lack of spontaneous activity, loss of attention, memory. Sometimes it may be normal, but patient cannot be bothered to remember. Okay, that is actually in frontal lobe syndrome. A loss of abstract thought, cannot understand proverbs and all, perseveration, change of affect, so sometimes they behave childish, okay. Okay, so there are different tests for children, adults, the gifted and the disabled. Some tests are administered individually, others are administered in groups. Most of the neuropsychological assessment we have to observe each and every time. So it will be observed one-on-one. Some are easy to administer and score, others are very difficult to use. There are a few tests, the scoring only takes actually 45 minutes. Okay, so the most popular and frequently used tests are the Wechsler scales. The second most frequent used intelligence test is the Stanford Binet. And this is most important. So the neuropsychological assessment actually started with this criminal investigations. That is the most, especially in developed countries like America, Canada, USA, Australia, or Europe, because this is actually started with medico-legal assessments. What they do, the patient actually met with an accident because the person is undergoing surgery. So we do assessment before the surgery. Okay. Then after few days later, after the surgery, then few days later, again we do the assessment with the Form A and Form B. It's a different version. So what, if anything actually goes wrong, then they compare with the first and second assessment. If there is any problem with the first and second assessment, then they sue the doctor. They get millions of dollars. So this is the way actually started with neuropsychological assessment actually initially. So then each of them, whatever it may be, they undergo surgery, brain related surgery, they definitely do the neuropsychological assessment before and after. So then they can actually sue the doctor. Okay. So even if there is any problem, if anything actually wrong, then because of the person was before he was working in a company as a manager, he was actually working fantastically. He was managing his managerial activities, but after the accident he couldn't manage. So in this assessment, if the doctor writes all those things, detailed report, so then they sue the person who actually hit the car or vehicle. So this is actually very, very important, because mainly the neuropsychology uses for medico-legal purposes. And what are the goals of assessment? The goals of neuropsychological assessment? Miller outlined 3 broad goals of neuropsychological assessment. That is actually diagnosis, to determine the nature of the underlying problem. Secondly, to understand the nature of any brain injury or resulting cognitive problem and its impact on the individual as a means of developing a rehabilitation program or offering advice as to an individual's ability to carry out certain tasks. So that is the second goal. The third one, lastly, assessment may undertaken to measure change in functioning over time. So that's what are the changes, because maybe the person actually started assessment, after 6 months or 1 year later, what kind of changes actually happened, because the function actually improved or not. So such as to determine the effects of surgical procedures, because is that because of the surgical process something actually went wrong, or anything actually because of rehabilitation, cognitive retraining activity, something actually over period, some kind of changes. So these are all the goals of assessment. So what are the methods of neuropsychological assessment? The major, so this is the main, we are actually approaching the main level approach of neuropsychological assessment. The major approaches are actually standard battery approach or fixed battery. That's what I said before. The standard battery approach is actually nothing but actually one battery. Battery contains 21 tests or 13 tests or 15 tests or 10 tests. So you have to use that battery approach because it measures attention, concentration, memory, learning, language, whatever. So all the functions, but you have to use whether the person actually, even some aspect the patient may be adequate, but we have to use the technique with the standard approach method. So that is called actually fixed. So whether you like it or not, you have to use all the battery. Then only you will get the composite, the total global deficit score. Okay. So in that way, like a standard battery approach, or then the other one actually flexible approach. So that is actually hypothesis based. So just check the patient, because some area, because the patient's intelligence is very fine, we never do any intelligence test, or the attention is fantastic, then we never do the attention aspects. So like that, because we pick some of the tests. For example, I said before, frontal lobe syndrome. So we know that the psychiatrist or neurologist clearly written that there is a frontal lobe syndrome. Then what we do? We just do only frontal lobe related assessments. That's all. We never bothered about other things, because we know that is what actually majorly affected. So in that way, we pick the thing actually flexible approach method. So the other one, diagnosis of neuropsychological disorder. So the psychologist can start screening for cognitive and behavioral problems by using either one of the following techniques or sometimes all the above, all the below. So what we do history taking, interviewing, test taking, intelligence testing, and testing other functional areas. So this one I'll just brief because this is most important. So history taking, the history of presenting complaint, including investigation, treatment, and referrals already arranged and provided or not. So past medical history, significant past disease, illness, or surgery, including complications, trauma, or anything. Then medical history, that is a history. When you take the history, the medical history, now and past, prescribed over the counter medicines, allergies or whatever, family history, especially with parents, siblings, and children, and social history about smoking, alcohol, recreational drugs. They used to take the recreational drugs, accommodation and living arrangements, marital status, occupation, pets, and hobbies. These are all we include in that. And systems review, that based on the physiological systems, the cardiovascular system, respiratory system, gastro and nervous system, muscular system, genital system, all those things, because these are all we do interview taking. Then psychologists use structured interviews in order to determine what kind of neurological problems the patient might be experiencing. So, okay. So in that overall, what they do, this so that history taking, then this includes gathering medical history of the patient and their family, developmental milestones, psychosocial history, and the severity and progress of any history complaint before and all. These are all we do. Okay. So then psychologists use structured interviews in order to determine what kind of neurological problems of the patient might be experiencing. Then we have a short portable mental status questionnaire, that is a 30 mark score questionnaire, so that I will explain later. Then neuropsychological impairment scale and patient's assessment of own functioning and structured interview. So test taking, the scores on standardized test taken by children is a strong predictor of future judgment. So we'll see briefly about attention. That is actually an essential element of cognition. Attention has been characterized in two ways, either a source or capacity or a skill or of resource deployment. There are three different types of attention. That is what, because in clinical setup we do, when it comes to attention, what we do, there are three types of attention. One attention is actually focused attention, then second one is sustained attention, and third one is divided attention. Focused attention refers to the capacity to perform a task in the presence of distracting stimuli. Okay, so the capacity to listen to conversation in train station, to identify a friend in a crowd, to be able to study in a noisy hostel are some examples of focused attention. So the second one is sustained attention, refers to the capacity to attend to a task on hand for a required period of time, so that the patient, the person will be sitting for longer time. For example, watching 3 hours of movie, 3 hours of lecture, or 1 hour of lecture, sustained attention. The third one, actually divided attention, is the capacity to attend 2 or more tasks simultaneously. So the divided, so what we say, divided attention, so that they have attention dual task at a time. Okay, then we have processing speed. The processing speed is nothing but mental processing speed, that is composite measure, which requires rapid processing of information. So so that is actually a thinking speed. So how fast we are thinking, because for example when you are riding a bike, so the motor actually says put brake, because of that you have to think, because if your mind actually should say, the brain should say that put brake, so then the motor will work. So that how fast your processing is actually happening. So when you assess dementia patients, so their processing speed is very, very slow, very, very slow. Okay. So the next is actually motor performance. Motor speed is depend on reaction time, how fast you react it. I said before that driving scooter, such that speed is greater wherever the reaction time is faster. Okay. Then sensory acuity in general way, sensory acuity means how good your senses are at doing what they should do. Okay. The higher the number of sensory receptors in a region, the more accurate the sensory perception of the region. So the next one, actually working memory, is a cognitive system with a limited capacity that can hold information temporarily. The working memory refers to the capacity to hold and manipulate the information for ongoing process. Then learning and memory, you are all psychology students, but even then I just briefly say one line. Learning and memory are the capacity by which a person is able to gain experience and retain it. That's what encode. First, what you do, somebody says, first you listen to the person and the lecture or whatever, first encode it, then retrieval. So okay, these are all the encode, store and retrieve. First encode it, then store it actually short term or long term, or retrieve it at any time. So learning and memory are interdependent process. Okay, memory process are divided into short term and long term memories. So in that there are many things. When you talk about memory, it's actually more, but when it comes to the neuropsychological assessment, what we do in memory related, we have actually short term memory, long term memory, short term verbal memory, short term visual memory, long term verbal memory, long term verbal memory, then short term visuospatial memory, long term visuospatial memory, all those things, because there are many things actually involved when you do neuropsychological assessment. Then we do intelligence, language. So that is actually how, because that is what basic assessment can be assessed clinically through an interview. A basic battery also measure verbal comprehension among a multitude of language functions. Okay, then what we do, calculation, and then the other important area is actually the function is actually visuospatial and constructional skills. Visual constructional ability is the capacity to construct a design using either a paper and pencil or blocks or sticks. Okay, this ability is the capacity to translate visually perceived information into a three-dimensional object or a two-dimensional figure, especially with these dementia patients or old age patients. They have more visuospatial ability problems. So what they can't even draw three-dimensional pictures. I'll show you later. Okay, then what we do, then we do problem solving and judgment. So we have execution, how decision making capacity, then mood, thought, thought content and personality and behavior. So this also we assess, because not only abstract thinking, executive functions, mood, thought content, personality and behavior. A person with a personality disorder often has difficulty interacting with other people because they are functionally different. Okay. While a person with a mood disorder has a normal interactions outside their periods of extreme sadness or happiness. Because see, with this, with mood, thought, content, and personality and behavior, so the neuropsychological, when we do assessment, most of the time, because with especially with the neuropsychiatric conditions, because their cognitive functions will be affected. Okay, now we come to brief mental status examination. There are many brief, that is 30 points, to understand basic level understanding. So basic level understanding, that is, see, I'll show you, this is the mini mental status examination. So what are the areas actually involved here? So you can see that, that 5-point scale here, what we do very basic. This is to just screen, because we have Montreal Cognitive Assessment scale also. There are many mini mental, because in that we have actually different areas. That is actually, one is actually orientation, because that is the function is actually orientation, whether the patient is actually oriented or not. The second one actually registration, the patient is able to register words, verbal activity, verbal words or not. Then concentration and attention, the third function when you do many mental status examination, attention and concentration. We ask a simple mathematical ability. Then fourth one actually memory, then whether those 3 words actually to recall or not. Then language functioning, then visuospatial ability. These are all actually we assess through mini mental status. The mini mental status examination, the patient actually scores more than 26, so out of 30. Okay, out of 30, the patient actually scores 26 plus. The patient actually normal. That's what we say, according to their age, education, and gender wise. So based on the norms, because 26 is actually normal score. But according to Indian population, what I have observed in our setup, but even sometimes 24 also okay with our Indian group, but it's not actually normative level, but generally observation level. But the person actually scores below 26, what we say, they are actually 18 to 24, we just consider that a mild to moderate level impairment. Anything actually below 18 actually we consider severe level impairment. So then that is to do detailed neuropsychological assessment or not. So this is actually a wonderful tool to do a mini mental status exam. Anyone actually comes above 40 years, you can just do mini mental examination to understand whether you continue the long battery or not. So there are then I told you this. These are all the batteries you have for very short form. The other than what we have Montreal Cognitive Assessment Scale, because there is no point actually. I can discuss about it. Again, you see, because what are the functions here, you can see that visuospatial, executive, naming, memory, attention, language, abstraction, delayed recall, and orientation. These are all the functions actually assessed, but actually wonderful, very sensitive test. But the problem with this Montreal Cognitive Assessment Scale, because I'm actually certified, because even this one, when you do this only to do this screening task, you have to go to this Montreal Cognitive Assessment website, and around $140 or something you have to pay for 2 years, just to do Montreal assessment, because this actually is from 2018 they changed, because before that it was a free version, anybody can use it. But now you have to pay, and for every year you have to pay $140 to do only Montreal. So better what we do in general, we do the mini mental status examination to understand their basic mini screening. Then so again, the other wonderful test is actually called clock drawing test. So this is actually we ask the patient to draw a clock. So the instruction is very simple. Draw me a clock which says 1:45. Put the hands and numbers. That's all we say. So then we just ask for. The patient actually scores within 1 minute. It will be the person actually gets good score. But I'll show you one drawing test, because I have one video. So how the patient actually doing? Okay. So and cognitive screening tool from India. So what are the tools we have? We have actually PGI battery of brain dysfunction, revised Bhatia short battery of performance test intelligence verbal adult intelligence scale, PG memory scale, Nehar Benson test, Bender visual motor gestalt scale, and Hindi mental status examination, and domains assessed test, and Niman's neuropsychological battery. So I am the author of one of the authors of neuropsychological battery. So these are all the battery cognitive screening and detailed assessments tools from India. So so what is the IQ classification? You all know, because you are all psychology students, So we know that 140 and above, that IQ assessment, actually we say that the person is genius. 120 to 140 very superior intelligence, 110 to 120 superior intelligence, 90 to 110 normal or average intelligence, 80 to 90 dullness, 70 to 80 borderline deficiency, and below 70 definite feeble-mindedness. So we never call that mental retardation, because nowadays actually intellectually very poor. That's what we say. Okay. So this is most important to understand. So most of the batteries actually include this one. So why I'm actually highlighting this one, because these are all the functions because widely used in this. So we have actually frontal lobe related functions, because generally there are functions, because when it comes to brain, you don't even approach frontal lobe or anything. But in general, because these are all the tests actually to assess frontal lobe activities. But in general, because the brain is actually interlinked, so actually all the tests actually connection here and there, because it's interlinked connections. So what are the tests we do? We have actually motor functions, that is finger tap test. Okay, that is actually we assess motor functions, motor speed, motor coordination with the help of finger tapping test. Okay, that is actually nothing but hand tapping. So then attention we have actually, that's what I said before, sustained attention. We have actually color cancellation or digit cancellation test. Focused attention, we have color trials 1 and 2, that is A and B. Then expressive speech, repetitive speech, nominative speech, and narrative speech, these are all actually included in that. So then in that frontal lobe only executive functions we have, that actually includes verbal fluency, that is actually related to language. Then the design fluency, which is actually related to designs. So that one actually assesses with phonemic fluency test, design fluency test, and NBAC tests to understand the working memory issues, visual spatial working memory, with the help of NBAC test, visual and verbal, both NBAC, visual working memory tasks, and planning and set shifting tendency, that is actually execution. That is, we have Wisconsin card sorting test. So this Wisconsin card sorting test actually to score only takes actually more than 20 to 40 minutes according to their experience. So now we have actually computerized version, so better to use computerized version. Okay. Then we have a parietal lobe function, okay, visual perceptual ability. That is, we have motor free visual perception test. Actually, this is for children as well as adults. Okay. Visual conceptual ability, the picture completion, visual constructive ability, block design, visual recognition, picture objects, apraxia, symbolic and sequential acts, sensory perception, tactile, finger location, tactile form perception, finger localization, tactile form perception. These are all actually the parietal lobe functions. And reading, that is again reading a passage, reading comprehension, writing to dictation, copying, all those things, calculation, age appropriate sums and all. So then we have temporal lobe. I told you before only that functions with learning and memory. We have verbal comprehension, token test, verbal language and memory, raise auditory verbal learning and memory, which again it takes actually around 10 to 15 to 20 minutes to assess based on the patient's response and the performance. Visual learning and memory, memory for designs, visual memory, complex figure test. So these are all we do. Apart from that, we do, I already told that mood, thought, personality and behavior. So that person, whether their coping strategy, how they are actually coping with their moods, mood swing, and because of what kind of behavior is affected, because of behavior, what kind of neurobehavioral, like that neuropsychological functions affected. These are all actually we'll see. Okay. So then another one is actually again we do, because when we talk about mood and personality, then coping style and behavior, then emotional intelligence is very important. So knowing and managing one's emotions and recognizing emotions in others are part of emotional intelligence. That is the problem with everyone. That's what I said before. They don't have insight to understand other person's feelings or emotions, because if you interview with psychosis patient, the mother will be suffering, father will be suffering, no money, but the person will be demanding unnecessarily without any insight. So then we have to do EQ also. So then this is very, very important. Malingering, the fake disorder, or because to get too much money, that insurance companies, they fake that they have some impairment, like that they behave. So in that we have malingering kind of tests also to understand that the person is actually they have whether faking behavior or not. We do neuropsychological assessment. Okay, so these are all the memory tests we have. We have actually for memory, you can see these are all the tests you have. For attention, you have these many tests. It's all actually used internationally, because most of this are actually standardized according to their country and culture. And for intelligence and executive functions, these many tests we have. And practical aspects of testing. So the selection, matching the test to symptoms, that is the major, because when we do any assessment, whether the symptoms are actually matching with the tests or not. So the close observation to standardized instructions, because we can't even give any kind of our own instructions, because it's already written material. We should follow the standardized instructions. And again, the scoring, matching with observed responses to possible ones. Then interpretation also based on the interview, then based on the normative data. Then again, what else? The report writing report of procedures and findings, follow up, whether the patient actually need to meet other professionals, because maybe the psychiatrist would actually refer to us. So maybe he needs some kind of neurologist referral also, sometimes neurosurgeon also, we don't know. So maybe that follow up based on neuropsychological or the other significant others. Disposition, appropriate referral for further diagnosis and treatment. So then what else? Then see this. This is the way we create a neuropsychological assessment profile. So each function wise, we actually put it all the tests. Then functions based tests, test based scores. That is their percentile scores, because any percentile score actually below 15th percentile, what we say the patient actually impaired. That is according to the statistical norms. We have actually, we have percentile and T scores. That's what we use in our neuropsychology or any other battery to understand. So if there is anything actually high average, a 75 plus 75 percentile actually high average, then average actually 16 to 74 percentage, mild impairment 7 to 15th percentile, I mean 14th percentile, mild to moderate, this 2nd to 6th percentile. Now moderate to severe, that it goes below level. Okay, then we have to check the reliability and validity of the test may be affected by many factors like mood, status, motivation, effort, and cooperation. Because that is what, because they always think that they go to any kind of neuro centers or Niman's kind of a setup. They think that they are actually mad. So that kind of they no motivation, no effort, also no cooperation, also sometimes mood also affected. So because of that, the score will be, will be affected. So then what are the technical and methodological issues? So then we have a test administration, standardization of administration, then users qualifications, whether that there is adequate norms or not, then reliability, validity, and confidentiality. So to use test batteries or not, so that is the question. No, many batteries have known psychiatric properties. Okay, so there is adequate reliability and validity. Use of standardized procedures permits comparison of one patient with others, even if the other are tested by different clinicians. Okay, when we do even 2 or 3, because the results should be the same. So that means there is a valid one. Test cover a wide range of cognitive functions and behaviors, because all the functions should be there, because whatever I mentioned, all the attention, concentration, memory, visuospatial ability, executive functions, motor functions, processing speed, and everything. So psychologists will likely be required to make clinical judgments that are based on training, experience, and intuition. Okay, so that's what, because the patient sits in front of me, then I have to think what can be done, what are the tests we have to understand, do. Efforts to increase their skills and achieve reliable, valid, and useful conclusions are worthy attempts. Okay, so we test all of your thinking abilities such as memory, concentration, language, etc. Look at your score on these tests and compare to people with your same background, age, education, gender with the normal level. The patient actually abnormal, we compare with the normal group. The person's score below the expected range in certain area, this help us to know what things are more difficult for you. So we can make recommendations to help you function better. Then we usually give several different types of tests, and neuropsychological evaluation can take anywhere from 2 to 6 hours depending on the number of tests given. So in general, neuropsychological assessment, because we do one one time only we do all the assessments, because it's a clinic, because in the institute kind of setup, what we can actually ask the patient to come for 2-3 times, and we can actually asking, sir, why you are using the manual version, where we have already computerized the tab version, because some tests are actually we can use tab, and some tests we can use it manually also. That is actually fine, but you have to update the version. That's all. One who specializes in the test to adults may be undertrained and unqualified to administer test to children. So that is most important, because somebody will be very, very good at with children and with adults also. These two, you have to keep it in your mind. So limitations of neuropsychological assessment, again, varying interpretations and uses. Two psychologists may interpret the results differently and take different course of action. Is that right? That's what happens. Uncertainty of measurement, because it's all psychological, right? Because of neuropsychology tests are attempting to measure things that are not directly observed. There is always going to be a gap between what a test is attempting to measure and what is actually measures. That is what we do, reliability and validity and standardized procedures. So changing circumstances as time goes on because of changes in psychological theories and advancements in technology, psychological tests only remain relevant for a time, because because this generation, because what we developed in 1960, some test is there, because some till date some people are actually using those tests, which is not at all applicable to this current generation. So you have to change it. Then it's actually, then we have to check the cultural bias also. Okay, so I conclude this session because what we have seen. So that cognitive testing is used to identify overall intellectual skills, to identify cognitive strengths and weakness, to assess the presence of learning disabilities, to predict academic success, to examine brain dysfunction, and to assess personality. Okay, the purpose for which the test was developed. Okay, we must understand the biopsychosocial influences that might affect the scores. Stress level and coping abilities are associated with cognitive abilities. Okay. Okay, thank you. Then I will show you some of the cases if you have time. If you give me some 2-3 minutes, then I'll show you some cases. Is that okay?
Sure, sir.
Now you can see, because this I told you before that clock drawing test, the patient actually, I asked the patient to draw 145, put the hands and numbers. Okay, so just see how he is drawing, and the patient is actually more confused, and he just put the numbers, you can see very clearly. That's all, because the rest of the things actually missed. So this is to understand the patient's the executive functions, because the execution actually not happen. It's not working properly. You can see that, no? Then there are other case studies I have, so I'll show you. So then I'll show you. Then you see, you can see, because here we can, I'll show you. So this is the one, because the patient actually took, I don't know, the patient's age is actually around 31 years. Okay, 31 years, having head injury. So you can see that the patient actually, we asked the patient to cancel 9 and 6. You take whatever the time, okay, because there is a norm for 10 minutes for this age group, but the patient actually finished within 6 minutes, that is 5.57 seconds. You can see around 100 errors he committed. So that means it is severely impaired. See, there is no attention, you can make out. And not only, then you see the patient actually copying skills, he got 36 out of 36. Then immediate recall, the delayed recall, the IR means CFT, IR means it's immediate recall. So immediate recall, he scored only, you can see 1, 2, 3, 4 out of 36. Then here you see the delayed recall, he scored 2, 4, 6, 7, 8, 9 and 10, that's all. See, 30-year-old, because the person should score at least 26 plus, then only the person is normal according to the norms. Again, you see that the executive functions, the patient actually scored very, very poor scores, creating novel words, So again, you see the patient actually scored, because within 1 minute he actually on an average it's actually 3.3 or maximum 4 words actually per minute. And animal names also, you see, he said only 5. So you see, this is the one case. The other one actually is there is a Parkinson's disease patient. You can, because this word spatial ability, I told you, I talk about spatial ability, because here you see spatial ability, the patient actually very poorly, the copy skills are very, very poor. And that mental speed activity, I talked about processing speed. He couldn't even complete the thing because he couldn't even understand how to code the thing. 1 means this, 2 means this, 3 means this. The person couldn't even code it because there's digit symbol substitution test. See the clock, you see that I showed one clock with video. Then now you see this is what 145. According to the patient. So the execution, the copying skills very poor. I told this is the copying picture. How he copied, he copied like this. This is what copying skills with the patient. So, and and you see another one. See the copying skills, and you see delayed recall. So I don't know because it completely disturbed. Apart from that, we did actually memory task. See, this is auditory verbal learning and memory. You can see here. So this one, you see, he scored 4 delayed recall. Delayed recall actually only 1. That's what you can see. Only 1 response. So there is actually 15 word list, but he could actually remember only 1. See how the mental processing speed, and the other person actually how he did the clock drawing. You see how severely impaired. So this is the these are all the tests, and not only that. That's what the mood. I discussed about mood and personality. Because when we do the depression scale, you see all 3. The score he scored 21. So that 18 itself cut off. The 18 is a severe depression. So the person actually scored 21. So that they have depression also. See the other one. Even you can see here. See. This is the delayed recall copying, the delayed recall complex figure test, how poorly performed here. So you see how he did this thing. See again, you see that clock drawing. Can you see? There are 140 couldn't even understand how to, because where the 12 and 2 and all. So you see the diagram how we couldn't even do any spatial ability. So that the spatial ability refers to that root finding difficulty later, okay. And see there are many patients. You see the patient how there 17 minutes, the patient actually took 17 minutes, around 18 minutes, plus many errors. See that, okay. So this is the complex figure test, okay. This is what we give the patient to draw, and this is with the executive COVA, controlled oral word association test. Ask the patient to more novel words from start with F or A or S or animal names. And this is the auditory verbal learning and memory task. So because whether the person is able to code it and store it and retrieve it short term and long term, that is immediate recall and delayed recall. And this we do for working memory, digit attention, digit forward and backward. And logical memory, we give this small story to encode it and retrieve it later, immediate and delayed recall. And this is the coding task which I showed you earlier. Because that with patient's performance, here you have to code it according to the alphabet numbers and symbols. And this is the digit cancellation. They have to cancel 6 and 9 as fast as they can. And is a trial making. This again focused attention task. They have to point numbers from 1 to 25 as fast as they can. Then the other task actually there is called actually divided attention, dual task at a time. That is again begin with 1. So how they have to do 1A, alphabet and numbers. So you have to alphabet and numbers go in the ascending order, 1A, 2B, 3C, like that. Okay. So thank you so much. Is there any questions?
Thank you, sir. Now the platform is open for discussion. The participants having any questions can drop your questions in the chat box. It will be read out.
You can ask about anything, no issues. You can ask any kind of problems, because with not only neuropsychology, because like that, anything related to that, because you're all psychology students. No, please ask anything. It should be more interactive. Then only you'll understand. So be ask openly, anything you can ask, no problem, because you have more doubts, related to assessing tests, this, that, and all. Anything you can ask. I'm ready to answer anything. So no questions. Just think, anything you can ask. Generally, even sometimes, because whether it is meaningful or not, no issues. You can actually ask any kind of questions. I'm ready to answer. No problem. Don't worry about anything.
So there's a question here from Pallavi Joshi.
Yeah.
Could you tell us about your experience of developing your test?
Okay, so that is actually because that's what because when I went to NIMANS as a postdoctoral fellow, because that is not my postdoctoral work actually, because my postdoctoral work actually related to HIV and cognitive functions, and it's like interlinked with neuropsychiatry, neurochemistry, neurology, and neurovirology, that kind of study, because I was doing in a higher level. So then I was in the neuropsychology lab because they did this neuropsychology battery related data, because they already collected 7 years. They kept it like that only. Then I went and asked the madam was actually very upset. What, man, because nothing is happening, because I already wasted so much money for this particular project, and nothing is actually coming out, because I have the data but I don't know how to complete it. Then I asked madam, can you give me the data? Let me just look at the data. Then I looked at the data. I told madam, I can finish it within 1 month. Can you give me the data? Then she gave me, and there are few data incomplete. Then I thought, okay, then under me there are 2 students. Actually, they collected other data also. Then incomplete one portion. Then I started working every night, continuously around, I think 1 or 2 months. I was sitting in the lab. I that continuously in the lab, because I up to 2 or 3, I don't know, because it's kind of in my mind always the numbers will be running around, because then every day the same thing I do. One day I just submitted, madam, take it. That's what I finished it. Then she asked, how did you finish? I don't have any idea, because I finished it. That's all. Because this is, I don't know. This is the way, because when you start, because really very big data, and to do analysis also, to understand the concept also, and making this normative, all those things really hectic. All the time the numbers will be running inside. So I didn't even take any leave also, because that is the way I actually completed. And but I won't say, because I may be interested in statistics, so I did it nicely, because I don't feel anything, because I didn't even expect that my name will be there in the, because already 7 years many others are actually worked hardly, very hard, so I worked very hard only, but I never thought that my name will, because the thing that the director thought that you worked more than other students, so they put my name, because I didn't even expect that, like that only. It exactly completed the neuropsychology battery.
Thank you, sir.
Yeah.
Question from Hanina. Do we administer every test that are listed for each section of assessment, like for memory, attention, etc.?
Yeah, very good question. So then you will definitely become a neuropsychologist. Very good. So okay, so because that's what the intelligence, because that is what you have, that intelligence. So what you have to do, see, the person actually sits in front of you, because you have attention. There are 5 tests. Don't do all 5 tests. One attention, one focus, to just do. One divided attention, do it. One sustained, finish it. That's all. Then you have 2 or 3 memory tasks. Take one memory task and finish it. One visuospatial ability, just finish it. One like that. No, take each function, one test would be the best option, and that is a good way of thinking. Because you couldn't, because if it is like a little difficult, then you do 1 or 2, because they're very difficult to observe and predict the patient. then you do one or two, but otherwise no, just one test in each function is more than enough. That is a wonderful thing, and that is a good way of actually thinking and analyzing. And whether it is reliable or not, definitely it is reliable, yeah, because we are measuring the attention and concentration and memory tasks. Definitely is reliable, and you can do one test in each and every function. You may not do everything. So that is what the problem. So that is called actually flexible battery approach. That is a tailor made. You can actually take one test and you can actually complete the test, or you can actually use the battery approach. When you take a battery approach, then you have to conduct all the tests. That is the problem. So you can actually take a tailor made. That is actually you can flexible manner. That is a good idea actually doing.
Thank you, sir.
Yeah.
Question from Anita. To what extent can this test be matched to MRI test?
MRI, yeah, brain MRI. Oh, very good. Again, that's a good question. So, because, yeah, so let me check, because MRI, okay. So, for example, see, I will tell you, very good. This is a good way of actually asking questions. So, we have, okay, one second, because with explanation I will give, because otherwise you don't understand what is. Okay, so for example, you take this, okay, this is MRI, brain MRI, okay, understand. So what we do neuropsychological assessment. Not only, this is like for example, take it as an example. So what we do, because you can see the arrow mark, there are like a white color, you are seeing, no? That white are actually kind of that is called white matter disease. That is actually that by periventricular white matter disease. So that is sometimes it is age related also. Because of the age, this area is actually impaired because of the less blood flow. And this area white means that dead neurons only, because the neuron there is no active neurons here, because that is actually there is no active neurons here, that is white area. So that means that area is impaired. So when you do neuropsychological assessment, because especially you can see that the kind of a parietal and temporal area, that white color. So when you do neuropsychological assessment, when you do the verbal learning and memory, visual learning and memory definitely will be affected. And some kind of areas actually in the frontal area also it is there. So in that way, what happens when you correlate with our MRI images plus with the neuropsychology data, it will synchronize. So most of the epileptic surgeries nowadays, we have epilepsy, we have surgery. What we do, they do MRI and everything, EEG and everything, and along with they do detailed neuropsychological assessment to understand which part of the brain is actually impaired, whether it is a left side or right side. Okay, so then the neuropsychological assessment actually to detect that is a purely left side, because sometimes that scan actually gives left side. Even sometimes it is like sometimes it shows both the sides. With the help of neuropsychological assessment, it's 100% related to verbal. That is like verbal issues actually impaired. So you can actually they open left side of the brain and do the surgery. So it is actually really there is a link between MRI brain and neuropsychological assessment. Yes. Any other question?
Thank you, sir. A question from Dr. Usha Chandra. Statistical tests are based on sampling. If sampling is not proper, it may lead to wrong analysis. Could you elaborate the basis of such test?
So can you repeat the question in a second, because there was some kind of disturbance here. Yeah.
Sure, sir. Statistical tests are based on sampling. If sampling is
Correct.
not proper, it may lead to wrong analysis. Could you elaborate the basis of such test?
Correct. So what happens, because in general what we say in psychology, what we say minimum any statistical based analysis, at least we need actually at least 30 numbers. Okay, at least we ask 30. Then you can see in neuropsychological battery also, there are few tests actually we have actually collected not more than 34 also, because there are very few cases, because illiterate population we got only 34. But if you get more number of subjects, like 100, 200, 1,000, no, the generalizing, you can easily to generalize things very nicely. Even because 30 also we can do, but the standardization will be fantastic when you actually having more number of subjects than the less number. But at least statistically, because technically 30 is actually okay, but less than 30, but it is really very difficult to generalize anything. But clinical data, for example, psychiatry problems, because they have some kind of clinical correlation. Yeah, they are going to check. We won't get very rare cases. For example, if you take a Parkinson's disease or something like that, so very rare, very rare. Monthly 1 or 2 patients only will come to the center. So you can't wait for longer time. So you have to wait for 30 patients, you have to wait for 2 years, like that. So in that way, that is a clinical. So you can actually do clinical assessment as well as the this thing. To do some kind of research, it will be fantastic because you can actually do some case report. But when you are going to standardize some kind of technique to understand the person's problem or overall global deficit, you need definitely you need more numbers. Then not only more numbers, because more numbers, for example, even why it took longer time with the neuropsychology battery, because when we collected the data, there may be extreme data. So somebody, for example, if you take illiterate data, because there is 6 and 9 cancellation, illiterate actually, for illiterate we won't give this kind of paper pencil task, because for example some kind of other tasks, because coding, for example, the literate data. So one person actually, he actually took only 5 minutes and 2 errors. Okay, very minimal. The other person actually took 17 minutes and 54 errors. Okay, these two are extreme data. Even the score is fantastic because it's 5.57 and 2 errors, very good score. But I can't use it in my normative data because this is very extreme, but very wonderful data. That is genius category. The other one actually very worst data. So these two extremes I delete it and make the thing actually normal probability curve. Put the algorithm, that histogram. Based on histogram, I just select the data. So whatever the extreme data, I delete it. Then again the missing whatever the data, again I collect it and normalize the data. Then only I do the analysis. Then only we'll get adequate and normal standardized thing. Otherwise it is difficult. Thank you.
Thank you, sir.
Yeah.
So there's a question from Vijay Kumar. Is it possible to test lobe activities within a definite time?
Yeah, that is a good again, because that is what the everybody is actually having some kind of wrong idea, or I can say that it's maybe a old thought, I can say like that, because with the same idea I went to Canada, because I was actually in Nimans and all, they talk more about the lobe wise functions. Okay, so in Canada nobody actually discuss about lobe wise functions. Okay, everything is interdependent. So I was giving actually a big lecture like this, big lecture. It's actually 1.5 hours lecture actually completed. Then I finished. Nobody was actually much interested listening to my lecture. Then I finished. Then they were telling, "Hey, Gopu, these are all actually outdated. No, in 2000 only we finished all lobe-wise functions. Now where are you?" Like that they asked. That is they asked in 2008 to 14. Okay, so then most of the things actually interlinked, but there are few assessments purely to assess executive lobe-wise, frontal and temporal, parietal and this thing, because we know technically we know these are all the things actually assesses this one. So the better version of actually understanding is actually to do fMRI, functional MRI, to understand, because functional means the person actually does some kind of activity, some frontal lobe activity, frontal lobe tests or functions tests. So then frontal lobe areas, whether it is active or not. If it is active, definitely that actually measures, because if there is a 2-3 areas actually linked, because active, then the test actually measures 2-3 area. So that actually you can understand through only fMRI. Okay, functional MRI only. So that general MRI you can't make out. So then you do, because we don't have any fMRI machines in India, because very rare only. So very expensive machine. It's around more than 6 lakhs, or I don't know, more than 25 lakh crores or something like that. I don't know. So it is very difficult to do that. But generally, yeah, there are few tests. Yeah, generally we say, yeah, low bias we can assess. But in general, because the latest approach is actually interlinked functions only. That is actually good, very latest update. Otherwise, we are actually sitting in 2000 only. So that's what there are actually lobe-wise functions. The frontal lobe syndrome. It is very clear. It actually measures 100% related to motor and executive functions and number, working memory tasks. All those things are there, attention and all. So it's all. They created frontal lobe battery. That syndrome is there. So through that kind of thing, you can actually do. But other things and all, it's actually kind of interlinked. It is little difficult to explain. Doing assessment you can do, but when you explain it, you can't explain properly. But there are because even nowadays in India they are doing low bias functions. It is not actually, it is actually outdated. That's what I say. Yes.
Thank you, sir. There's a question from Priyanka Dikshit. In case we are in a situation to investigate a standardized questionnaire in regional languages, should we check the reliability and validity after translation, or just translate and use?
Yeah. So because in general what we can do, because this demands actually it's kind of multicultural approach only, because we got patients from different different sectors, because we assessed Hindi patients, Kannada patients, Tamil patients, Malayali patients, Bengali, because we have all the population. Because we actually developed, you can see in the battery backside all the language version will be there. So in that way, what we are doing, because there is no issues, because we are asking arm, cat, hammer, all those things. These words culturally there is no much problems with, because you can ask in Kannada whatever they say, in Malayalam whatever they say that particular word only. Because if it is actually kind of, when you are assessing like personality or any other tests, because it should have actually adequate language related changes, cultural free tests. But here what you are doing, arm. So whatever the arm in Tamil or Malayalam or Kannada or Hindi or English, whatever, the same word you are going to replace. There is no issues with that kind of issues. But if there is kind of statements, then you need actually with the language department, with the coordinate with the language department, you have to translate properly, and it actually measures exactly the same kind of the statement actually the same manner actually in English, in the same manner is it translated in Kannada or other local languages or not. You have to check with that, because when it comes to sentence, but when it's come to one word, there is no issues. Even we have actually memory task with paragraph, because that paragraph actually we actually did it with different languages, because translated with Hindi, English, Kannada, all those things. So that is actually the whatever the story we are going to say, the story actually applicable in each and every language. So you can actually use that if it is like that kind of thing. And and the instruction also, because the same instruction you are going to tell it in Kannada or Telugu or Urdu, it is okay. But otherwise, if it is statements, it will be a big problem. But if words, no problem, I think, according to my knowledge. But because we are using, because what to do, because the patient actually came from Afghanistan. How I will do, man? How I will translate? So then we don't have any norms also, because based on that we just do, we take it as a Asian group and we assess. Then we had other person also from other different country, and they don't speak Indonesia, because they won't speak that language. Because then how you do Indonesia, what they say in arms, then I just went to the Google translator and translated and wrote all the words, then I did it. So that way it is fine, because if it is a sentence, then it is a little difficult, because that is not standardized material according to statistics. Okay.
Thank you, sir.
Yeah.
Rest of the questions will be answered some other day as we are running out of time.
Yeah.
The participants present here are to fill in the Google form sent to you in the chat box.
Yeah, fine, fine. That's good. That's good. Please.
Now I request Sister Mari Evelyn to give reflective thoughts regarding the session.
Good evening to everyone present here, and especially Dr. Gopukumar. Respected sir,
Yeah. Thank you.
thank you for taking us from the psychological world to neuropsychological world. It was an intellectual feast, I must say. You helped us to see the differences in assessment in terms of its purpose, goal, approach, and its process and the outcome. It is said only an expert can explain a complex situation in very simple language, understandable to all, both the learned as well as the beginners. The clarity with which you explained all the difficult technical concepts with apt day-to-day life examples helped us to understand what it entails. You were able to tell us in a very short time the vast area covered by neuropsychological tests and the strengths and deficits of an individual assessed through these tests. You enhanced our knowledge on the various tests used to assess various cognitive functions, and we also realized how little we know and the kind of training we need to administer, score, and interpret the results. The tests seem to be very simple, such as tapping tests or clock drawing tests, but they give valuable information about the deficits experienced by the affected individual. Thank you for creating a desire and interest in us to know more about neuropsychological assessment. And I'm sure many of us, the participants, will start reading on neuropsychological assessment or neuropsychology by itself. We will surely remember you when we come across these technical concepts or the names of the test. You have opened a huge box of neuropsychological assessment, and we had only just a peep into it. And we also have realized the kind of training and guidance we require if ever we want to administer these tests. Thank
Yes.
you also for using the case studies, helping us to see the actual administration of the test and the kind of information we can derive from it. Surely the session was very interesting and enriching too. Thank you, sir.
Thank you, thank you, thank you so much, and thanks for your patience. And because again, again I have to talk about this attention because you people are actually very, very attentive, and thank you so much. And there was very interactive session. I'm so glad. So if I get another opportunity, if I come to Shivamogga or something, because I want to do some kind of live, kind of a workshop or anything, because because nowadays, because the neuropsychology, nobody is actually that training is not that much is there, and the cognitive training part also, cognitive
We need
retraining
that, yes,
aspects also.
cognitive
Yeah,
retraining.
yeah, correct. So yeah, that way, yeah, anyway, I'm very thankful to you people, so somehow I can actually educate few of them here. I'm really glad, and thank you so much for your this wonderful opportunity. I thank Anaga, only one of my interns, and she told me, yes, thank you, thank you so much, thank you so much, madam. Thank you, everyone.
Thank you, sir. Now, I would like to call upon Ms. Gautami from 2nd MSc Psychology to propose the vote of thanks.
Good evening, everybody. It is my immense pleasure to thank the dignitaries present in this event. Firstly, I would like to thank Dr. Gopukumar, Kumarpillai, Neuropsychologist, BNC Bengaluru, for enlightening us by giving information about neuropsychological assessments. Thank you, sir.
Yes, thank you.
Now, I would like to thank Dr. Rajani Pai, Director, Manasa Trust, for her presence over this program. Thank you, ma'am. Now I would like to thank Dr. Sandhya Kaveri, Principal of Kateel Ashok Pai Memorial College, Shivamogga, for her presence over this program. Thank you, ma'am. I would like to thank Sister Mary Evelyn, PG Coordinator, Department of Psychology, for her presence over this program. Thank you, ma'am.
Thank you.
Now I would like to thank Dr. Archana Kilbert, HOD, Department of Psychology, Kateel Ashok Pai Memorial College, for her presence over this program. Thank you, ma'am.
Thank you.
Last but not the least, I would like to thank all the students for showing interest in the session and cooperating with us. Thank you, one and all.
We request all the participants to please fill in the feedback form.
Man.
If you've already filled in the form, all of you can leave the meeting. It was a pleasure having you all. Thank you, sir.
Thank you, madam. Thank you, everyone. Thank you, bye.